The pancreatic pathology, people think it is mystified or difficult to understand. Here we are in these 2 days. I will try to demystify and make it as possible. So this will be our game plan for 2 hours, 1 hour today and 1 hour um, tomorrow. So let us start with the objectives. We will go through normal pancreas because knowing the anatomic location and the histology is very important to understand the pancreatic pathology. Then we will go through the WHO classification and more importantly, the practical classification and how to approach pancreatic lesions. We will see the IHCs used in pancreatic pathology, how to do frozen section and briefly on grossing what will be the points we have to include in the final report according to CAP protocol. I will just touch the cytology. I know cytology itself is a big topic, but I will tell you the very practical points in cytology. Then we will end it up with the molecular events. Objectives should be you must know how to do frozen section and grossing, recognize normal and pathology of pancreas. You must have a systematic approach. At the end of this discussion, you will be having that. You should know the essential IHC markers and the salient molecular changes in pancreatic pathology. Pancreas, how the name derived? Pancreas, pan means all, you know, and creas means flesh. So this is an organ which is completely fleshy. That's why it is called pancreas. And it is located in the retroperitoneum. And this anatomic location is very important because we all think pancreatic cancer is very bad, but most of the pancreatic cancers present with a higher stage. That's why they are bad. Stage by stage, skin cancer and pancreatic cancer are the same. But skin cancer we can identify before it grows, whereas in pancreas is in the retroperitoneum because of the anatomic location, it's hidden. By the time it compresses the adjacent structures or the bile duct and produce jaundice, we are not able to identify. That's why pancreatic cancer is very bad. And another thing, you see the stomach here, this helps us to pass the endoscopic ultrasound guided probe and biopsy the pancreatic lesions. So I will be talking about it in a couple of slides from here. I just want to highlight the anatomic proximity to stomach and pancreas. Grossly, it has 4 parts: head, neck, body, and tail. And tail is connected with the spleen and uncinate process. And the ducts of the main pancreas and the uncinate process, they drain into the ampulla in the duodenum. And morphologically or histologically, it has exocrine and endocrine. So I used to tell it's like a buy one, get one free. We have both exo and endocrine organs in pancreas, but exocrine constitutes 95%, whereas endocrine constitutes 2% with the supportive stroma that constitutes 3%. This anatomy is just important to know the biliary system. So right and left hepatic ducts, they join with the cystic duct. So the common hepatic duct becomes the bile duct, and the bile duct comes in, either it opens by itself in the ampulla or the pancreatic duct joins the bile duct and then they open up in the ampulla. And in Whipple's resection, they cut here the bile duct, and then if it is radical, they will give the whole pancreas. If it is modified radical, they will cut the at the level of the neck and then they give. So the margins will be proximal duodenal margin, distal duodenal margin, pancreatic shave margin here because the big blood vessels will be running here, and then the bile duct margin. So these are all the margins we are interested in the frozen sections and grossing. Sampling the pancreatic lesions in any organ, you should know what are all the tissues we may be getting from that organ. So it can be FNAC or endoscopic ultrasound guided. I told you in that previous slide, they pass the probe that has an ultrasound and core biopsy needle. So they can do ultrasound, identify the pancreatic lesion, and then they pass the core through the stomach, and then they sample the pancreatic lesion. But in that way, they get the mucosa and the adjacent pancreatic tissue also, that you have to keep it in mind. This is the CT guided biopsy, core biopsy. It can be guided or non-guided, but most of the time it is CT guided biopsy. Or they do partial pancreatectomy, distal pancreas along with the spleen. Or they go for Whipple's resection, where I mentioned the loop of the duodenum with the head of the pancreas and the bile duct. Or they may send tumor or samples from the pancreas for intraoperative frozen section. So these are all the 5 possible specimens from the pancreas we will be getting. And for FNAC and core biopsy, we have to have clinical, pathological, and radiological correlation. We used to talk about it in breast as triple test. It has to be applied in all the organs. And whenever I want you to take a snap of the screen, I will put this sign. Normal pancreas is arranged in lobules that are arranged like a zigzag puzzle. And salivary gland also looks like that. Many salivary gland and pancreatic histology are more or less the same, because salivary glands are also exocrine, but they won't have the endocrine. In the low power, you can identify the endocrineness, and you can see the septa in between the lobules. Lobules are the functional units. And in the lobules, you see the acini and the ducts will be running within the lobule or in the septa of the in between the lobules. So it will be intralobular or interlobular, and this is an example of intralobular, and this is an example of islets of Langerhans. This is the endocrine structure in the pancreas that constitutes 2% of the pancreas. And cartoonistically, you may be seeing the acini here continuing as ducts. And surprisingly, the myoepithelial cells are not there in the pancreas, at least to my knowledge, because we get the myoepithelial cells in all the secretory organs to compress the secretions into the duct system. I don't know why pancreas doesn't have myoepithelial cells. Some of you can take it up as a research project, how the secretions are coming out in the duct without compressing the acini. These ducts, there are mainly 4 types: intercalated duct, intralobular, interlobular, and main duct. And these are divided because of the anatomic locations and the size. And all the ducts will have a periductal collagen. That will be very less in intercalated duct, whereas in main duct it will be more. Why we have to know this? Lesions happening in the intercalated and intralobular ducts are non-palpable, and they are called as PANIN, pancreatic intraepithelial neoplasia. And the lesions arising in the larger ducts like interlobular and main pancreatic duct are known as IPMN, intraductal pancreatic mucinous neoplasm. So both PANIN and IPMN are connected with the duct. There is another cystic lesion known as mucinous cystic neoplasm that is not connected with the duct. That understanding is very, very important, because these are all the differential diagnosis. Whenever you get a mucinous cystic neoplasm, you have to see whether they are in communication with the duct. If they are in communication, they will be either PANIN or IPM. So this is the high power view to show the acini and mainly the endocrine structure, what we call as islet cells. And these are the acini. They will be more pink, whereas these endocrine cells, they won't have ducts. As you know, these are endocrine. They have blood vessels that acts as ducts, and they are more uniform in appearance. And see the salt and pepper chromatin pattern, how it is a fine chromatin uniformly distributed throughout the nuclei. We call it salt and pepper. This is one of the features of neuroendocrine tumor, and some of these cells may look like plasmacytoid. So those two are features of neuroendocrine cell. And these islet cells can be alpha, beta, delta, PP, or vasoactive intestinal peptide secreting cells. 75% are beta cells that secrete insulin. You all know alpha secretes glucagon, delta is somatostatin, and pancreatic polypeptide cells and vasoactive intestinal peptide cells. These are all the components of functioning components of the islet cells of the pancreas. This picture shows you there's a lot of lymph nodes all around. Why I am putting this, when they are doing a resection, you have to submit these lymph nodes differently. Usually surgeons will send it as different jars. For example, mesenteric lymph node, posterior anterior pancreatic or duodenal lymph node, suprapancreatic lymph node, intrapancreatic lymph node, infrapancreatic lymph node. Like that, they will label it and they send it. And the prognosis depends. For example, if it's a head of the pancreas lesion, if the lymph node mesenteric nodes are positive, the prognosis may be worse when compared to the nodes positive in the pancreaticoduodenal area. And one more thing you have to know, the lymph node metastases which are not regional, it is considered as M1 disease. For example, if it is the middle colic lymph node, then it will become M1. It is not N3. It will become M1. That you have to know for all organs. Non-regional lymph node metastasis is considered as metastatic rather than nodal metastasis, systemic metastasis. There are some interesting clinical presentations for exocrine and endocrine neoplasms of the pancreas. For exocrine pancreas, when in the duct is obstructed, it produces jaundice. And those are all the patients who come in a earlier stage. Earlier stage means stage 2 or stage 3. Because of the jaundice, we identify them. But if the lesion is in the distal pancreas near the tail of the pancreas, we won't get it until stage 4. The mucinous lesions produce migratory thrombophlebitis, and the acinar tumors produce polyarthralgia and fat necrosis. The endocrine tumors, alpha cell tumors or glucagon producing tumors produce 4Ds, dermatitis, diarrhea, diabetes mellitus, and DVT. And the insulin producing tumors, they produce Whipple's triad. Somatostatin produces diabetes mellitus, cholelithiasis, and steatoria. And the pancreatic PP cells, they produce Zollinger-Ellison syndrome like picture because they mainly secrete gastrin. And vasoactive intestinal peptide produce WADA syndrome, okay, watery diarrhea, hypokalemia, and achlorhydria. So these are all the clinical presentation of exocrine and endocrine pancreas. Coming to WHO classification of pancreatic tumors, we are now having the 5th edition of the Blue Book, and that has come in 2019. According to that 2019 update, the pancreatic tumors are mainly divided into primary and secondary. This classification is very, these types are very important. Whenever you see tumor in any organ, you have to say whether it is primary or secondary because the treatment is totally different. When it is a primary tumor in the pancreas, the exocrine tumors produce 95% of the pancreatic lesions, whereas endocrine tumors are only 5%. That you have to understand. In the exocrine pancreas, it's epithelial that comes in benign, pre-malignant, and malignant lesions. In the endocrine, it is a neuroendocrine tumor, neuroendocrine carcinoma, mixed neuroendocrine, non-neuroendocrine carcinoma tumors. In the benign tumor, we have acinar cystic transformation and serous cystoadenoma. In the pre-malignant, we already talked about PANIN. PANIN grade 3 is considered as pre-malignant. Now it is reclassified as high-grade PANIN. IPMN with low and high-grade dysplasia. IOPN is, this is intraductal pancreatic mucinous neoplasm. Here intraductal oncocytic pancreatic neoplasm and intraductal tubulopapillary neoplasm. The IPMN itself, now it's divided into 3. The IPMN subtypes I will be talking in a minute. So remember IPMN, IOPN, oncocytic, ITPN, tubulopapillary, intraductal tubulopapillary neoplasm. Then MCN is mucinous cystic neoplasm with low grade and high grade dysplasia. These are the pre-malignant conditions. And in the malignant conditions, it's a ductal adenocarcinoma, acinar cell carcinoma that can be solid and cystic, solid pseudopapillary neoplasm, and pancreatoblastoma. So these are all the epithelial tumors arising from the exocrine cells in the pancreas. The endocrine tumors have to be divided into non-functioning and functioning. And the functioning, depending upon the hormone they secrete, they are divided into insulinoma, gastrinoma, vipoma, glucagonoma, like that. And then the size is very, very important in neuroendocrine tumor. If you see a lesion less than 0.5 centimeter, then it is called microadenoma. These microadenomas are multiple usually, and they are seen in familial syndromes. When it is more than 0.5 centimeter, then only we can call it as neuroendocrine tumor. And we will talk about how to differentiate neuroendocrine tumor from neuroendocrine carcinoma and mixed tumors further down the discussion. We talked about WHO classification, but how to do a practical approach. First, we have to divide the lesions arising from exocrine or endocrine. In the exocrine, they can be from the acini, from the ducts, or from the stroma. In the endocrine, it can be either from the islets or from the stroma. And previously, we used to say this as a classification of lesions, congenital, traumatic, inflammatory, neoplastic. Now that system is gone, we are having a pattern analysis where you have to ask 4 questions whenever you see a lesion. Is it proliferative or not? Is it cytologically atypical features present or not? Is there invasion or not? Is there metastasis or not? So these are the 4 questions you have to ask: proliferation, atypia, invasion, and metastasis. And whatever answers you get, that gives a pattern of the tumor or lesions. So it can be non-proliferative lesion, proliferative lesion without atypia, non-invasive proliferative lesion with atypia, invasive proliferative lesion with atypia, invasive proliferative lesion with metastasis. That can be either regional or systemic. So this is the pattern analysis that is followed in almost all the organs now. So depending upon the pattern analysis, this is the flow chart given in the John Hopkins app. There are very nice apps. I will talking about them in the references in John Hopkins. And most of the gross pictures are from the atlas in that app. And you can see the beauty of the images further down the presentation. To make it simplified, first we have to see whether it is solid and cystic. And what are the differential diagnoses? It can be chronic pancreatitis, ductal carcinoma, pancreaticoblastoma, acinar cell carcinoma, neuroendocrine tumor, solid pseudopapillary neoplasm, serous cystadenoma, mucinous cystic neoplasm, and intraductal papillary mucinous neoplasm. These are all the possibilities. So first divide them into solid and cystic. When it is cystic, see is there any true lining epithelium or degenerative cyst. When it is true lining epithelium, if it is made up of serous cells, then it is serous cystadenoma or serous cystic neoplasm. When it is having mucinous epithelium, you have to see whether they are connected with the ductal system and what is the stroma around. If it is not connected with the duct and it is having ovarian type of stroma, then it is mucinous cystic neoplasm. If it is connected with the duct and the stroma is having more collagen, then it will become IPMN. And as I told you, it can be IOPN when you see oncocytic cells, or tubular papillary when you see the tubules. In the solid, you have to see whether they are arising from epithelium and stroma. When it is epithelial lesion, you have to see whether the glands are there, irregular glands, desmoplasia, and mucin secretion. If the glands are infiltrative with incomplete lumina, nuclei showing pleomorphism means variation more than 4 times. Take the smallest nucleus and the largest nucleus. If the difference is more than 4 times, then it is pleomorphism. And whether the tumor cells are seen next to the muscular vessels, perineural and venous invasion, and necrosis. You have to look for all these things. When these are not seen, then it is chronic pancreatitis. When these are present, it is ductal carcinoma. When you see solid cells with minimal or hyalinized stroma, you see whether they are acinar pattern with prominent nucleolus and trypsin and chymotrypsin positivity. And in addition to the above findings, are they showing squamousness? When you see acinar pattern with nucleolus, trypsin, chymotrypsin positivity, and squamousness, it's a pancreaticoblastoma. Otherwise, it is acinar carcinoma. When you see ribbons of tumor cells with the salt and pepper chromatin pattern that are positive for synaptophysin and chromogranin, it's a neuroendocrine tumor. When you have solid and pseudopapillary pattern with cells having nuclear grooves, and when CD10 and beta catenin are positive, then it is solid pseudopapillary neoplasm. If it is a degenerative cyst, you have to look for all the tumors because cystic degeneration can happen in any of these tumors. Cystic lesions, as I told you, are they connected with the ductal system or they are outside? When they are connected with the ductal system and they are palpable, then it can be IPMN, IOPN, and ITPN. If they are non-palpable and they are arising from smaller ducts, then that is PANIN. Two cystic lesions that are not connected with the ductal system, if it is mucin secreting with ovarian stroma, it is mucinous cystic neoplasm. If it's having a sieve-like pattern, then it is serous cystadenoma. And you have to remember, invasive carcinoma can be seen in any of the cysts. For example, MCN can be associated with invasive carcinoma, PANIN can be associated with invasive carcinoma, IPMN can be associated with the invasive carcinoma. We will see the examples down the presentation. So I told you the PANIN is a non-palpable lesion and IPMN is a palpable lesion, and they have the criteria. The size is, for PANIN it is less than 0.5 centimeter, whereas IPMN is more than 1 centimeter. Nowadays the sizes they take it in the radiology, because by the time we get the pancreas, we fix it, the size difference may be there from real to artifactual lesions. So they take the radiological size, and as I told you, PANIN is not visible. Microscopically, it shows only gastric foveolar type of epithelium, whereas IPMN can have 3 types of epithelium: gastric epithelium, intestinal epithelium, and pancreaticobiliary epithelium. Molecularly, GNAS is very, very important in the IPMN. This is one of the questions they ask in the exam. What will you do when you aspirate a cyst, and how will you process? Number 1, send it for cytology. Number 2, send it for amylase level. Number 3, send it for molecular change with GNAS. When GNAS is positive, it is IPMN. And here you can see 0.5, less than 0.5 and 1 centimeter. So what will happen if the lesion is between 0.5 to 1 centimeter? Give you a descriptive diagnosis with both as differential diagnosis. But when you see finger-like papillae, then it is incipient IPMN. Go for GNAS. When GNAS is positive, that confirms the diagnosis of IPM. So PANIN again microscopic, ductal connection, non-invasive. The lining epithelium can be flat or papillary, and architectural and cytological atypia may present, and they are mainly lined by gastric foveolar type of epithelium. Previously, PANIN is divided into 1A, 1B, 2, and 3, but now we follow the two-tier system. I will show you the two-tier system. Normal, PANIN 1A, 1B, PAN 2, PAN 3. 1A, 1B, and PAN 2, PANIN 2 are now low grade. and Pannin 3 is high grade. And this table gives the features how you differentiate normal from low grade Pannin and high grade Pannin. Normal, the lining epithelium is flat, cuboidal in shape, no stratification, no atypia. This cribriform and comedo, I will just leave it because it is seen only in the high grade panel. Okay, so normal, flat, cuboidal cells, no stratification, no atypia. In the low grade, it can be flat or papillary. They are columnar. The cuboidal cells become columnar in pannin. Stratification is present. Atypia is mild to moderate in low grade. Whereas in high grade, it is mainly papillary. The cells are again columnar. The cells are stratified. The atypia is very severe. And as I told before, the cribriforming and necrosis is very characteristic of high grade panel. You see the picture. So this is the two normal pancreatic ducts. This is more like intralobular duct, and this is interlobular. You can see flat lining epithelium, cuboidal cells without stratification or atypia. So this is normal. Here they become columnar, okay? But there is no atypia. It looks normal, and focally it is stratified. And so this is Pannin low grade, okay? So this is columnar cells. And look at these nuclei. They are mainly in the inner one third, or trying to go into middle one third. They are not in the upper one third, and all the nuclei are running in one direction. These 2 points are very, very important to differentiate low grade and high grade. In high grade dysplasia, the nuclei will reach the top of the cell, and there will be loss of polarity. I will show you in the pictures. And in addition to that, if you see cribriforming and necrosis, it is high grade. So this is low grade. This is again columnar cells, slightly thrown into papillary folds, and the nuclei are again confined within the middle one third of the stratification, and there is no comedo or cribriforming, and the polarity is maintained. Polarity means you draw a line all along the long axis of the cells, and all the nuclei will be traveling in one direction. That means the polarity is maintained. For example, take this cluster, and when you draw a line along the long axis, they will be parallel to each other. So that's what we call polarity is maintained. And to see the polarity, the nuclei has to be elongated. If the nuclei is round, we cannot assess the polarity. Unfortunately, many books are not mentioning that. They think it is understandable, because when it is round nuclei, you can draw a line along the long axis. There is no long axis for the round nucleus. So this is also low grade columnar cells thrown into mild papillary folds. Stratification is there, and the nuclei are confined to the middle one third of the cells. Here also the stratification, columnar cells, the nuclei are not touching. They are trying to come, but they are not touching the top of the cells. But the polarity is maintained. Look at here, all the nuclei are traveling in one direction. Look at here, all the nuclei are traveling in one direction. There is no cribriforming or comedonecrosis. Here you can see nice low grade, low grade. Probably this may be going into high grade, but it is still low grade because of maintenance of the polarity, and the nuclei are in the middle one third. You can see here cribriforming in the low power itself. So this is high grade. And look at the nuclei reaching the top, high grade. And look at the loss of polarity. I will show you the loss of polarity. See, this nuclei runs like this. This nucleus is runs like this. This nucleus is running like this. All the nuclei are running in different directions. For simplicity, I used to tell the traffic in the national highway is polarity maintenance, whereas traffic in front of Chettinad Medical College or Ramchandra Medical College, polarity is lost because all the vehicles are running in different directions. Whereas in national highway, all the nuclei are running in the same direction. So this is high grade. IPMN, as I told before, more than 1 centimeter. It can be anatomically, it can be from the main duct or branch duct. Histologically, it is gastric, intestinal, and pancreatico-biliary. Here, see the duct and see the lesion is connected with the duct, and it is visible more than 1 centimeter. So this is IPM. Again, dysplasia, what I mentioned is again mentioned in this table. So normal, low-grade dysplasia, high-grade dysplasia, single layer, nuclear basal, mucin present, no mitosis, no apoptosis. Low-grade dysplasia, stratified, polarity is main sign, no cribriforming micropapillae or comedonecrosis, nuclei middle one-third, mucin is absent. Normal mucin is present in low grade and high grade. Mucin can be absent, or in low grade, mucin can be present. Macronucleoli, again high grade. Polarity is lost, cribriforming, nucleus reaching the upper third and seen at the apex of the cells, and macronucleoli, mitosis and apoptosis. This is high grade. Dysplasia, this table is good for any tubular organ. For example, stomach, small intestine, colon, bile duct. You can apply this criteria for all the tubular organs. It's a beautiful section from the duodenum. You can see the major duct filled with lesion more than 1 centimeter, palpable. So this is from the low power itself, it is IPM. And when you see the lining epithelium, these are like gastric foveolar epithelium, and the nuclei are at the base, no cribriforming, no micropapillae, no comedonecrosis, and the polarity is main time. So this is low grade gastric type of IPM. Here you can see a lot of goblet cells, and they are arranged in villi. These are like intestinal type of IPM, again low grade. Here the lining epithelium is more like pancreatico-biliary, and there is micropapillae, there is cribriforming, and the nuclei are reaching the top, and loss of polarity. Look at here, this nucleus running in this direction, this nucleus is running in this direction, this nucleus in this direction, this nucleus in this direction. So loss of polarity. So this is IPM and pancreatico-biliary type high grade. Again, low power view of IPM high grade, higher power view of IPM higher grade. And remember, I told you any cystic benign lesion can have invasive carcinoma. This is a beautiful example. I have given the name of this beautiful pancreatic pathologist from University of Pittsburgh in the references. He takes very nice pictures. So this is a pancreatic distal pancreatectomy. You can see the cystic lesion along with the more solid lesion here. And microscopically, you can see invasive carcinoma, poorly defined glands, the growth near the muscular vessels, and apposar glands and glands infiltrating the fat. These are all the features of pancreatic carcinoma, NOS. So pancreatic cancer, and the associated cyst shows IPM with high grade dysplasia. So both IPMN, PANIN, MCN, serous cystadenoma can be associated with cancers. So you have to take adequate sections, and if there is an area of a doubtful lesion in the gross specimen, you alumbate that area, because we have to identify the tumors associated with the benign lesions. And we talk about perineural. This is a beautiful example of perineural and intraneural. And in the exam, there is one more mnemonic. Perineural invasion is seen in 3 P's: parotid, pancreas, and prostate. Please remember, parotid, pancreas, and prostate. Adenocarcinomas can have perineural invasion. This is a cystic lesion. You can see here connected with the major duct. and this is having a ATP1B1 BRCA fusion. So this classic of intraductal oncocytic papillary neoplasm, but you cannot diagnose it grossly. You have to look at the microscope. You can see the high grade, the low grade dysplasia with oncocytic cells that can be appreciated very nicely in the higher power. This is again low grade because they are not that much stratified, and all the nuclei are running in one direction. No comedonecrosis or no severe ATP. This is another intraductal lesion called as intraductal tubulopapillary neoplasm. This is a new terminology in this current WHO classification. This is also intraductal, but morphologically it shows tubular and papillary structures, and it is of high grade dysplasia, and this totally lacks mucin. So when you see abundant mucin, low and high grade dysplasia, papillary, without comedo type necrosis, it is IPMN. Whereas ITPN can have minimal to none of mucin. Usually it is high grade dysplasia. You see a lot of tubular structures, and comedo like necrosis is very common. So this is a classic picture of ITPN. Okay, here you can see a lot of tubules, solid, non-mucinous. You don't see mucin at all. This is again the highest power. See the tubules, high-grade dysplasia. Here polarity you cannot assess because most of the nuclei are round. So this is ITPN. This is another cystic neoplasm and multiloculated filled with mucin. And another thing I forgot to mention, these are seen, the mucinous cystic neoplasm are seen only in females. Remember, I mentioned we see ovarian type of stroma, so it is seen only in females. And more importantly, no duct connection. See the ovarian type of stroma, mucinous epithelium. This will look like a mucinous adenoma of the ovary, but it is in the pancreas. And this is low grade. All cystic lesions, whatever we have seen, PANIN, IPMN, or MCN, we have to see whether the dysplasia is there or not. And whenever there is dysplasia, we have to see whether it is low grade or high grade. When it is high grade, we have to see is there any adjacent carcinoma. Again, low grade MCN, you can see very nice ovarian type of stroma. And these ovarian type of stroma are nicely positive for progesterone receptors. And this is like a normal, and this is low grade dysplasia, and here it becomes high grade dysplasia. See the cribriforming. See the nuclei coming to the top. Okay, look at the low grade. The nuclei are still in the middle 1/3. So this is a mucinous cystic neoplasm with the invasive carcinoma here. Look at the number of mitosis. This is another invasive carcinoma arising in a background of mucinous cystic neoplasm. So the main differential diagnosis is MCN and IPMN. This is very, very important because the prognosis is totally different. This is usually seen in females, common in the tail, multilocular, no duct connection. This is very, 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 very important. Since it is not connected with the duct, endoscopically you never see mucin at the ampulla, whereas in IPMN, they are connected with the duct system, so they will produce a lot of ampullary mucin. Ovarian type of stroma is a must, and it can be associated with carcinomas. And whenever I have a table like this, I will remember the features of one of the lesion. So the opposite is for the other lesion. If you try to remember both, you will get confused. So I will try to know the features of mucinous cystic neoplasm or IPM, not both. This is another characteristic lesion, and you can see there are two lesions here. And this is, if you have seen once in your lifetime, you won't forget. This is like sponge-like pattern or sieve-like pattern, very, very classic of serous cystadenoma. And it can be, when it is multiple, you have to think of von Hippel-Lindau syndrome uh, because it is associated with abnormality in the VHL gene. This is another lesion with a sieve-like pattern with a central scar. And this is how it will look microscopically. This is the adjacent pancreas, well circumscribed lesion, multiple cystic spaces lined by cuboidal cells with a clear to eosinophilic cytoplasm. And when you do with the PAS, they will have a lot of glycogen, PAS positive, PASD negative material. And if you do VHL gene, they will be positive. I will show the picture down the presentation. This is another cystic lesion known as acinar cystic transformation. Previously, it is called as acinar cell adenoma. That can also be multiple, and these are pancreatic duct. See how beautiful this gross image is. See one of the duct running here. Microscopically, this may, on the low power, this may look like a serous cyst adenoma. But when you go to high power, you can see acinar type of cells as well as ductal type of cells that are seen best in the high power. These are ductal type of cells, whereas these are acinar type of cells. If you are in question, you can do double immunohistochemistry. The ductal cells are brown and they are positive with CK19, whereas the chymotrypsin is red and they are staining the acinar type of cells. So the acinar cystic transformation or cystic transformation of acini shows both the ductal and acinar type of cells with a lot of cystic spaces that can be connected with the ductal system.